Well, hello, everybody. My name is Mirvat Alasnag. I'm a guest editor at Radcliffe Cardiology, and we have a special edition that's coming out on women's cardiovascular health. And with me are some lead co-authors, Ahmed Krimly from Saudi Arabia and Julia Grapsa from United Kingdom. So I'm going to turn to you, Julia, first. And I know that one of the articles that you're leading is about disparities in care in women with heart failure. Can you expand on that a little bit?
Yes, thank you so much for giving us the opportunity, Mirvat, to explain more about this hot topic. It's gender differences in heart failure. And with that, for example, we focus on every presentation of a woman who is coming to the hospital with heart failure. And for example, if we only think about the aortic valve, to show you an example, like that women may have less calcification but presenting with a more significant hemodynamic compromise, or for example, that we tend to, now we have new imaging modalities to diagnose a patient with heart failure, and of course a woman earlier rather than later. For example, what we are focusing now is the myocardium, the fibrosis, mechanism to detect early fibrosis in these patients with valvular heart disease, and then to set the new thresholds of preventing, from them going into to advanced heart failure. Another important parameter is that there are no references. We have a lot of studies focusing now on women, but we know that this needs to be indexed to the body surface area, that the references and the normal values are different from women and men. We just started seeing the first ever large studies in echo that they include women. So a lot of work that has been done, a lot of work to be mentioned, and great disparities between men and women.
Absolutely. And, I don't want to leave this conversation without tapping into something you quickly mentioned. You are a structural imager. And in that space, where are the areas that you think, with respect to tricuspid, mitral, perhaps even TAVR, what are we still missing in terms of the evidence when it comes to offering these therapies to women?
We see that a great percentage of women that they are presenting with valvular heart disease, they are getting undertreated. And practically, while they will complain of symptoms for a long period of time, eventually the patients the women that they're getting either tricuspid procedures or mitral or even further TAVI that has been proven, they don't get the same equal treatment than men. Now, what are the parameters? Are they underestimating their symptoms? Are they, for example, the general practitioners underestimate the symptoms? This is actually ongoing research to demonstrate exactly where are the gaps in evidence and what is needed from us in order to get this gap more even and bridge this, what we mentioned, the gender gap. But it has been demonstrated also that, for example, women, as I said, they may present with less calcification, but more hemodynamically compromised. They will get better results post-surgery or TAVI, but also they will benefit from getting the right treatment at the right moment.
Absolutely. And I'm going to turn to you, Ahmed, because you actually have a subspecialty that's quite rare, and we don't have enough men who are into this area, which is cardio-obstetrics. We do see women with valvular heart disease presenting during their pregnancy. So which are the diseases or valvular disorders that you think warrant intervention during pregnancy and can't wait?
So basically, it depends on how the woman herself is presenting during pregnancy. If the woman most likely going through pregnancy without any symptoms, most likely she will go through. However, patient with severe mitral stenosis, that's usually the patients or the pregnant ladies I get worried about, and hoping that nobody will call me at night for them. Then followed by severe aortic stenosis. However, again, mitral stenosis is worse in pregnancy compared to aortic stenosis, despite both not that great be having to going into pregnancy.
And should you need to intervene on a pregnant woman, what do you advise the interventional team to do as precautions to protect the fetus and so on from radiation exposure?
So definitely, most of the procedure, our cardiac procedure, are within safety limits of the radiation exposure for the fetus. And regardless, we do protect our patients and fetus, and taking priority in doing the procedure safely. And hemodynamic is the first important thing, actually, to maintain patients in good hemodynamic state. not taking patient with cardiogenic shock, for example. That's very poor outcome for the mother and the baby. Then regarding radiation, whatever, for example, in intervention, in coronary intervention, obviously the radial axis is better for radiation protection compared to femoral. And just covering the abdomen of the pelvis with the patients, of the mother during with late, actually, it's reduced the amount of radiation, and depending on TE. So I understand in TAVI, so most of the places don't use TE anymore, or minimize the use of TE. However, TE and TAVI and ballooning aortic valve in need, or ballooning mitral valve, that will reduce the amount of radiation used during the procedure.
Absolutely. And I'm going to turn to both of you very quickly to ask about a concept that we've learned a lot about in structural heart, which is the heart team, the multidisciplinary team. You know, it used to be the interventional cardiologist communicating with the surgeon, but now the heart team has expanded and is actually involving the imagers, and it's involving anesthesia and so on. So what do you think we need? What kind of models do we need? Is it only case by case, or do we need a team that is there all the time to discuss every case? What are your thoughts, Julia?
You're right, Mirvat, because many times we will see that we have different opinions about a patient. I think it's important, first of all, the caring clinician. We have seen the patient, we know their functional capacity, we know what their patient is doing in the everyday life. That's fundamental. Then, as you say, it's important to have the anesthetist, the care of the elderly physician. So the heart team has expanded in order to get all the parameters in, the quality of life, because we don't want to give false expectations on the patient and their family. So we have to reach to a very responsible decision as a consensus from the whole group. So this is what we usually do. And I believe a lot in the heart valve clinics, and also, if one step further, if it's possible in the future, the dedicated women's heart valve clinics, because we follow a different pathway when compared to men, and this is also an additional way to bridge the gap.
Absolutely. And something that Julia mentioned was expectations. So now for pregnant women, the subsequent pregnancies, what should they expect, and what kind of advice do you think we should be giving them?
So in general, usually, if a woman goes through her pregnancy without any major complications, that's a good sign. However, in general, we advise patients not to get pregnant at least for 1 year after her pregnancy, before she getting to second pregnancy, if she has significant heart disease. And still, we have to monitor the patient, because disease progression is there. So maybe the aortic stenosis was moderate, now within a year or so could be severe. So we have to monitor the patient. So again, for pregnant patients or ladies who wish to get pregnant, definitely seeing or planning the pregnancy with your cardiologist is a must for such patients.
My final question to you, Ahmed, how do we get the community interested in cardio-obstetrics? Medical community, how do we get the cardiologists interested in the field, more trainees going into it, more teams that are expanding and involving the obstetrician as well as the cardiologist?
So basically, it's very fascinating subspecialty, because now you're not only taking care of general cardiology patient, but you're taking care of a cardiology patient with significant disease during pregnancy, which is a risk stress factor for them. So awareness. So basically, you have to make the public, make your colleague aware about the subspecialty and the special needs. So sometimes the patients get denied because of the supposedly high risk of pregnancy. But in the matter of the fact, the pregnancy, although there is some risk, but it's not thought by other people. So awareness, teaching, education, all of these are actually very important in widening the field for obstetric cardiology.
Thank you, Ahmed. And my final question to you, Julia, is you and I met in London, PCR London Valve, and we had sessions for women and in cardiology. From your perspective, what else needs to be done to, open the horizons for women and their careers in a field that is as competitive as cardiology?
So practically, it's important to motivate women to understand that this is a very interesting field, that more and more women colleagues need to be a part of it. There is no reason not to think that there is poor quality of life or there is any compromise in your life that has to do with cardiology. Now, for example, cardio-obstetrics is such an interesting subspecialty, or structural imaging, that more and more women are going there. Or of course you, Mirvat, that you are one of the best structural interventionists in the world. You know, you, for example, people like you inspire us of say that this is the dream, and we young women will keep chasing the dream. So congratulations to you and everything you have done, and inspiring also younger generations to come.
Well, thank you, and thank you, Radcliffe Cardiology, for giving us the platform, and hoping that this edition is going to open the doors to discussions on careers and women's health in particular.